السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم وأشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبد الله ورسوله. This is the session of debates in the GN. The session had 4 case scenarios with 8 distinguished speakers. They will debate about the questions and answers related to the diagnosis, prognosis, and management of these 4 cases. Really, it's not typical debate because in some of the issues, there is complementary visions. In other, they will just present you with the evidence, whether from the guidelines or from the recent trials or the research that is around, and you have to choose. We will not have a voting system because we've cut 40 minutes out of the session. Session should be 2 hours. Unfortunately, because of the time constraints, we will take only 80 minutes. So we've cut 40 minutes out of the session. There will be no time for the debate. Actually, the presentations are not in order as it shows in. So we will start with this session, with this presentation, and I'll call for Dr. Mohammed Abdel Gawad, Professor Dr. Hisham El-Ghunaimi, because they will co-debate this session with me. So start the session, the slides, please. خلاص ما احنا سيبها زي ما كانت. Okay. So we'll start with the prognosis and what is the diagnosis. This 33 years old female, she had a proteinuria of 4 grams and her creat is 3 milligram per deciliter. Her blood urea is 110 milligram per deciliter. She shows, beside the proteinuria, an active sediment or at least microscopic hematuria with a positive ANA but negative anti-double-stranded DNA with a consumed C3, and there is no family history of kidney disease. The patient, as expected, had a biopsy, and as you can see in the biopsy showed 9 glomeruli. All of them showed no obsolescence. Only they showed segmental peripheral duplication of the basement membrane, focal endocapillary hypercellularity, and mild mesangial proliferation. 4 out of them showed cellular crescent, and 2 showed segmental tuft sclerosis. If we recall the early morning session, this is an active vasculitic lesion, if you accept that. Tubule shows mild injury, and interstitium showed moderate lymphocytic infiltrate. The arteries and arterioles were unremarkable, and Congo red was negative. So what's next in this patient? Would you start an autoimmune and infection survey, or would you do an immunohistochemistry and EM? This is a hypothetical question.
Actually, the case that Dr. Ahmed presented is nearly, the pathology is nearly a membranoproliferative glomerulonephritis with the clinical presentation of rapidly progressive glomerular disease. For sure, immunofluorescence is mandatory in this case because, as we all know, that MPGN is newly classified according to the type of the deposits in the immunofluorescence. It is classified into mainly immunoglobulin related. Immunoglobulin is the dominant in the biopsy, plus minus commonly 3. This is immunoglobulin mediated. So in this case, we have to exclude monoclonal gammopathies, especially if there is an old patient more than 50 years. Infections, especially hepatitis C virus. Also, bacterial infection, malarial infection, and other parasitic infections may be excluded according to the clinical presentation of the patient. Autoimmune disease, for sure, especially lupus nephritis, systemic lupus erythematosus, and maybe also Sjogren syndrome and mixed connective tissue disease according to clinical presentation. And finally, it may be idiopathic, but actually it is very rare to find an idiopathic membranoproliferative glomerulonephritis diseases. The second sector, the MPGN may be component mediated, and for sure in this scenario we will have C3 glomerulopathy or C4 glomerulopathy, and both of them can be divided into dense deposit disease or glomerulonephritis according to the site of the deposits on electron microscopy. Finally, negative immunoglobulin, negative complement 3 in a sector of diseases that may cause endothelial swelling and endothelial damage. As we know that MPGN was classified before according to electron microscopy into type 1, type 2, and type 3, but actually this classification is misleading because there is overlapping in the type of the deposits. For example, in type 1, the deposits may be C3 only, C3 IgG, and type 3 is the same. That's why the new classification ignored the electron microscopy classification and is now classified according to the immunofluorescence. So immunofluorescence is mandatory, exclusion of infection and autoimmune diseases are mandatory in this case. Dr. Ahmed.
Okay, so as you see, the patient had the immunohistochemistry, which is essential in this situation, as well as the EM. We have to have both together. As you can see, the immunohistochemistry was significantly positive for C3, both in the GPM and in the mesangium. As we previously mentioned, when you have a C3 by 2 logs more than immunoglobulin, if there is an immunoglobulin, you are entitled to diagnose C3 glomerulopathy. Then the EM did confirm the previous histological diagnosis. There is diffuse thickening of glomerular capillary basement membrane with extensive subendothelial electron dense deposit, as well as frequent subepithelial humps. And when we found both subepithelial and subendothelial, this goes classical with type 3 MPGN, previously known as this, which we can put under the C3 glomerulopathy right now. And the mesangial area showed expansion as well. The patient had a C3 glomerulopathy with an activity that is 40% crescentic type. Screen ya shabab. So what's next? Will you pulse her with steroid and start an MMF? Or would you do a genetic testing because you don't know this patient would be a responsive one or a non-responsive one? Professor Hisham.
Good evening, everybody, dear professors and colleagues. Happy to share in EST Congress in its 2025 version, and hope the Congress will deliver fruitful scientific content as every year as usual. As regard the first question, whether to give pulse steroid and MMF, the management of C3 glomerulopathy differs according to the clinical presentation of the patient. Whether the patient is presenting with mild disease with proteinuria less than 1.5 gram, or moderate disease with severe proteinuria, or RBGN as the patient encountered in our case. So, as regard the evidence of management of C3 glomerulopathy presenting with RBGN, we should give the patients glucocorticoid in combination to other immunosuppressive drugs in the form of MMF or cyclophosphamide. We will start to give the patient pulse steroid for 3 days, followed by high-dose oral steroid to be tapered over 6 months, in addition to either cyclophosphamide 1.5 to 2 milligram per kg per day orally for 3 to 6 months according to clinical response, or we can give MMF at a dose of 1.5 to 2 gram per day orally in 2 divided doses for at least 6 months. However, if we have an evidence of decrease in factor H, whether due to genetic cause or acquired autoantibody, in such cases we can have a trial of plasma infusion or preferably plasma exchange in case of autoantibody-mediated factor H deficiency, and also for concern of volume overload in uremic patients, we can give a trial of plasma exchange 3 times per week for 2 weeks. If the patient is improving, we can continue further. If no response, it is advised to stop plasma exchange. It is important before management of C3 glomerulopathy to rule out the presence of post-infection or infection-related GN and to evaluate for the presence of monoclonal gammopathy, especially in older patients more than 50 years of age. As we all know, C3 dominant glomerulonephritis doesn't only mean C3 glomerulopathy. Differential diagnoses include monoclonal gammopathy of renal significance and post-infectious GN, and only to diagnose C3 glomerulopathy, C3 deposition within the glomeruli should be at least 2 orders of magnitude greater than other immune reactants. So this differential diagnosis is very important in the management. The second question as regard the genetic testing, if we take a look at this KDIGO controversy conference held in 2017, we will find a statement saying that there is no clear benefit of genetic analysis except if there is an option for kidney transplantation for evaluation of the donor. If we will make genetic testing, the genetic testing should entail complement factor 3, complement factor H related proteins, and complement factor I and B, and all these genetic testing should be confirmed by an amplification method to give us an idea about the ultrastructural changes in these genetic variants.
Okay, Hisham agreed that we have to rule out infection, as we've mentioned in the first question, and he pointed to the value of immunosuppression, in particular, maybe MMF or cyclophosphamide along with glucocorticoids in that patient after excluding a complement abnormality, and this can be done by genetic testing and O2 antibodies. Where plasmapheresis can be of help, though usually is not. Regarding the genetic testing, you should start doing genetic testing, and the updated consensus for the genetic testing in nephrology point out to the need for doing genetic testing beforehand of transplantation in such cases, especially if there is a family history, as Professor Hisham alluded to, and to decide or not to give long-term immunosuppression. So our female with her proteinuria and consumed C3, she and the positive C3 glomerulopathy in the biopsy, she started MMF and steroids for 2 months, initial improvement, then she had recurrent relapses. So she did a genetic testing. And the genetic testing showed a copy number variant in complement H-related factors 3 and 5. And these, 1 and 3. And this copy number variant in CFHR 1 and 3 is really a very misleading type of genetic testing. It might be precipitating to C3 glomerulopathy of the autoimmune type, not of the genetic type, and it might confer other autoimmune disorder and susceptibility to diseases like lupus nephritis, for example, which can be again in the differential of this patient. And on the other hand, it might present with nothing. Like, for example, in Nigerian population, it constitutes 36% of the normal Nigerian population. So the interpretation of this genetic testing was a bit inconclusive, although related to her scenario. So is it C3 glomerulopathy or atypical HUS, and what about that? Let's move on.
As Dr. Ahmed mentioned, the copy number variation analysis revealed that our patient is at increased risk of atypical HUS. Of course, C3 glomerulopathy and the atypical HUS are two faces for one coin. Both are complement-driven mediated kidney diseases, and both share a common pathophysiological aspect where there is dysregulation of the alternative complement pathway. If we take a look at the literature, we will find many or several case reports and case series that there is sometimes concurrent C3 glomerulopathy overlapping with atypical HUS cases, and sometimes atypical HUS or C3 glomerulopathy may come sequentially in the same patients with phenotypic change between the different phenotypes.
So what's next? The next question would be, would you stop an MMF or would you shift to a C5 or complement inhibitors?
Actually, the case is going more toward the C3 glomerulopathy as there is no clinical presentation of thrombotic microangiopathy in the presentation of the case. So regarding the use of eculizumab in the management of C3 glomerulopathy, basically because the pathogenesis of C3GN is due to dysregulation and the hyperactivity of the alternative pathway of complement. So it is logic to try eculizumab in these cases. This is one of the most recent case series of 26 patients. Some of these patients were children and some were adolescent and some were adults. Some of these cases presented with cellular crescent and rapidly progressive glomerular disease as our case, and some of them responded to eculizumab. That's why some experts suggest that eculizumab may be used in resistant cases, especially if they are presented by RPGN, in addition of the combination of the immunosuppressive therapy that we mentioned before. Eculizumab can be administered as 1,200 milligram intravenous every 2 to 4 weeks. If there is no evidence of disease stabilization or improvement after 3 months of the therapy, eculizumab should be discontinued. The case progressed to renal failure till creatinine reached 9, and the patient started hemodialysis. The patient wishes for transplantation. So what is next? The question now, would you proceed for transplantation of this case? If yes, would you accept her mother as a donor or any other related donor? And Hisham will answer this question.
Now our case progressed to being end-stage renal disease patients, and we have a wish for transplantation. First of all, we should identify the challenges facing us in transplantation. Number one is the risk of development and unmasking of atypical HUS in genetically predisposed patients, with the trigger being the kidney transplantation itself. The second challenge is the risk of recurrence of C3 glomerulopathy in patients. Most of the time they are on MMF and steroids, which are the drugs of the most proven evidence to manage C3 glomerulopathy in native kidneys. As for the first challenge with the risk of development of atypical HUS, we have evidence from a large observation study of 273 patients with atypical HUS. 11 of them developed de novo atypical HUS following renal transplantation, and 2 of them had complement abnormalities in either complement factor H or complement factor I. In another retrospective study of 57 patients with atypical HUS who underwent transplantation, 39 of them had identified complement genetic abnormality. As regard for the risk of recurrence of C3 glomerulopathy, if we take a look at KDIGO guidelines, there will be no specific data to inform a decision surrounding a transplantation in C3 glomerulopathy, and the recommendation reflect expert opinion and limited case reports owing to the rare nature of the disease. But C3 glomerulopathy recurs at a very high rate in allograft, leading to accelerated graft loss in 50% of the cases. And this is a recent systemic review published in 2024 for the risk of recurrence of C3 glomerulopathy following kidney transplantation. We'll find that the risk of recurrence varies between 60 up to 84%, with recurrence occurring as early as half a month up to 14 months following transplantation, and recurrence leads to accelerated graft loss at least in 50% of the patients. However, KDUKI commentary on KDIGO 2020 on clinical practice guideline for the evaluation and management of candidates for kidney transplantation didn't exclude patients with C3 glomerulopathy from the potential of being kidney transplant recipients. However, the risk of recurrence should be discussed with the candidates. Concerning the second question, if we accept living-related kidney transplantation, of course, related donors may share the same pathogenic genetic variants, increasing the risk of recurrence. So if we like to proceed to living-related kidney donation, we should screen for genetic or acquired causes of complement dysregulation in both the recipient and both the donor, to guide treatment and inform the risk of recurrence. For example, if we are faced with a patient with a deficiency in complement factor H due to genetic nature, this patient can undergo transplantation, but by performing periodic plasma exchange before transplantation till the disease is quiescent in nature, and then we continue
Dear
thereafter
doctor, your
after
time is up.
transplantation.
No, 2 minutes. No more time. We don't have any minute for any more time. So thanks, Hisham. Thanks, Muhammad.
Dr. Ahmed.
We've done with the presentation, and the issue is the case, as you can see, gives you the essence of the need to identify the whole scenario from the beginning, to give or not to give immunosuppression, to study or how to study, and to transplant or not to transplant. Thanks, Dr. Muhammad. Thanks, Dr. Hisham. And we'll move on. Unfortunately, we've cut 10 minutes from each one and no time for discussion. Let's move to the next presentation. Can you put it up, please? So what's next? Next is, okay. So this is, okay, this is the debate in membranous nephropathy. I invite Professor Dr. Muhammad Mamdouh and Professor Dr. Muhammad Hisham Hassanin to the stage, and we'll debate this case together. So I'll start by giving the history. Mr. KK is 54 years old, male. He presented to the clinic with a medical history of hypertension and old treated hepatitis B virus infection that turned PCR negative. His creatinine was 1.3, his urea was 46 milliliter per minute, ACR was around 5 grams per day, and his anti-PLAR was positive around 50 Randall unit. His current mitigation were the entecavir for his maintenance hepatitis B virus clearance, olmesartan and dapagliflozin for the proteinuria with the febuoxostat once daily. He had a kidney biopsy, of course. It showed 11 glomeruli, non-globally sclerosed, diffuse moderate capillary basement membrane thickening, tubules were unremarkable. He has immunohistochemistry showing diffuse C3 and IgG deposits. The EM was not done. And the first question for this very intriguing patient, is this a primary anti-PLAR because the anti-PLAR is there, or is it a secondary hepatitis B, although the HBV is PCR negative now, but you know that hepatitis B can induce membranous nephropathy. Please, Professor Muhammad Hisham.
Thank you so much for the kind invitation. So, you know, just to recap, we have a 54-year-old gentleman that came in with nephrotic range proteinuria, basically nephrotic syndrome, and elevated PLA2R antibody levels. So the question is this primary PLA2R associated membranous nephropathy? To answer this question, we have to go back to 2009 when PLA2R antibodies were discovered by Dr. Lawrence Beck. And in this study, he found that PLA2R antibodies were available in 70% of patients who had what we used to call idiopathic membranous nephropathy. So to answer this question, we have to go over the diagnostic accuracy of PLA2R antibodies. So this is a study that basically showed the sensitivity, specificity, positive predictive and negative predictive value. So if you can see here, and I'm not sure if my pointer is available. So this is the cutoff value of the PLA2R antibodies. So at low values, the sensitivity is 100%. And at values above 40, the specificity is 100%. Our patient had approximately, the PLA2R antibodies was 49.8. So can PLA2R serologies replace kidney biopsy? The answer is yes. Dr. Shane Bobart from the Mayo Clinic group, they did this study, and they found that 79 patients out of 101 who had a primary biopsy-proven diagnosis of membranous nephropathy, biopsy did not change the management. And that's what led KDIGO to basically recommend that once we rule out all other secondary causes, if the anti-PLA2R antibodies are elevated, we do not need a biopsy. Since then, Dr. Sanjeev Sethi at the Mayo Clinic and Dr. Tiffany Kaza at Arcana Labs, they've discovered more than 50, 60 antigens right now. And out of these antigens, we have 2 antibodies right now that are available commercially for testing in the US. All the rest here are only available on tissue biopsy. This is a paper that we basically published in NDT, and this is basically our vision for, let's say, 2020, 2030, 2035, when we have mass spectrometry and we have PLA2R negative, we're gonna basically type for all these antigens and then basically determine what kind of associations are available with each of these antigens. So could this patient have PLA2R associated membranous? My answer is yes. Dr. Mamdouh.
Okay, we'll now hear the opposite view.
Good evening, my dear colleagues and professors. First of all, I would like to congratulate all my professors and colleagues for the success of our annual scientific conference. I will discuss the other side of the coin. Is this patient can be, to resume, this patient is a hepatitis B patient that developed nephrotic syndrome with positive antiplur and negative BCR for hepatitis B virus. So I will begin my discussion by asking these 2 questions. Can hepatitis B virus cause membranous nephropathy even if treated? And the second question, is antiplur antibodies still highly specific for primary membranous in this setting, I'm insisting, in this setting of hepatitis B virus infection? So I will answer this. First of all, we all know that there is occult hepatitis B and occult hepatitis C. Occult hepatitis B, there is no serological markers in blood. And in this study in 2013, they found that in 500 patients with occult hepatitis B, they found that 9 cases has hepatitis B antigens inside the kidney. So their conclusion that occult hepatitis B and hepatitis C might be implicated in hepatitis B associated nephropathy. So if the patient has a negative BCR for hepatitis B, he can also has a hepatitis B associated nephropathy. Another case report, exactly the same like our case. He has undetectable hepatitis B virus DNA, and they found hepatitis B antigens inside his kidney, and the patient was nephrotic syndrome, and the patient was presented by membranous nephropathy. And they suggest that hepatitis B related kidney disease should be considered even if the patient has undetectable hepatitis B virus DNA. This is the first question. So in a patient who has a negative BCR can have hepatitis B virus associated nephropathy. The second, is antiplur is still highly specific in hepatitis B virus patients? The answer is no. In this study published in the American Journal of Nephrology, they found that a renal staining for phospholipase A2 receptor inside the kidney, we all agree it is highly specific in primary membranous, but still in hepatitis B virus patients, they found it in 64% of patients. 64%, this is a very huge number in hepatitis B. So, and it was very close associated with the serum antiplur. So their conclusion that a renal biopsy plur positivity was common in idiopathic membranous and hepatitis B virus associated nephropathy, but rare in other secondary causes. Another article which was to differentiate or to compare between hepatitis B virus-associated nephropathy and idiopathic membranous nephropathy in hepatitis, or which is complicated by hepatitis B. They compare 50 patients on both sides, and they found that it's very important. In hepatitis B virus-associated nephropathy, they found that serum hepatitis B virus markers were negative in 12%. Negative in 12%. And 8% was positive anti-BLAR in the serum, and 10% were positive for BLAR in the kidney. And they had stronger IgG1 and C1q and weaker IgG4, which is more specific for primary membranous. And there was no difference between the serum and renal BLAR in idiopathic membranous and hepatitis B virus-associated nephropathy. Another study is that comparing BLAR-positive hepatitis B virus-associated nephropathy and patients with idiopathic membranous, and they found that similar clinical manifestations on both sides, but renal blood show increased mesangial expansion in hepatitis B virus-associated patients, and it showed very favorable outcomes and more remission in the hepatitis B virus-associated nephropathy. So my opinion for the first two questions is that based on the illustrated evidence, hepatitis B virus-associated membranous nephropathy can occur in patients with negative hepatitis B virus PCR. In other words, you shouldn't exclude secondary hepatitis B virus-associated membranous nephropathy in patients with negative hepatitis B virus PCR. It can be idiopathic or it can be hepatitis B virus-associated. Anti-BLAR is not highly specific for primary membranous in patients with hepatitis B virus infections. Hepatitis B virus is among the commonest secondary causes to be associated with anti-BLAR. To differentiate between idiopathic membranous and hepatitis B virus-associated nephropathy, we should deal with positive anti-BLAR with caution. As I said, don't rely on it only. We must look for other differentiating points, like the presence of direct virus antigen inside the kidney, IgG subclass, and C1q staining. And because of these parameters were not done in our patient, I am not sure that this patient is primary or hepatitis B virus associated nephropathy. He can be both. أنا مش هقدر أقول إن هو secondary فقط. It can be both, to be honest. This is
Okay, this would be the second question. Whether we're sure it's primary or not, would you treat this patient with a cyclophosphamide-based regimen, as in Ponticelli, or a CNI, as in cyclosporin?
As you all know, cyclophosphamide is one of the cytotoxic therapies. And for the sake of time, I'm not going to go through this table, but what the point that I'd like to make is cytotoxic therapies have been proven to be effective since 1995, since the Ponticelli regimen was basically introduced. I'd like to point that the studies that were done using cytotoxic regimens have the highest follow-up periods in any therapies that were actually studied. We're talking about 10 years. This is another study that was published in JASN, 11 years. So cyclophosphamide, as we all know, some of the advantages: it's cheap, it has a higher rate of sustained remission associated with better long-term outcomes. It's usually not nephrotoxic like CNIs, and it is associated with lower relapse rates. However, it's not for everybody. It is gonadotoxic, it is hepatotoxic, cardiotoxic, associated with bladder cancer and hemorrhagic cystitis, myelosuppression, and pancytopenia. So this patient had a PLA2R antibody level of 49.8. As you know, medicine is not, like fixed. You have to, use the clinical judgment. So I would say it's close to 50, so I would label this patient as high risk, and I would give him cyclophosphamide.
Okay, now we hear the other face of the coin with Professor Mamdouh.
My choice for the preferred initial treatment in such patient will depend on two factors. We have, again, a patient with hepatitis B virus on treatment, and he has a membranous nephropathy. Which immunosuppression I will give him? As I said, I have two factors. I should concern or think of the severity of the nephrotic syndrome, which will be discussed according to the risk stratification of the KDIGO, and all of us never forget the risk of reactivation of hepatitis B virus with each immunosuppression. We should take care of this. For the first one, For myself, this patient, according to the GDI, is a moderate risk. PLAR is 49, patient proteinuria is 5.5 gram. Patient has a moderate risk for progression. This is the first time. According to the KDIGO, moderate risk patients can be treated by calcineurin inhibitors or rituximab. Cyclophosphamide is for high-risk patients. I cannot give and expose patient to cyclophosphamide. This is the first question. Our patient is medium-risk patient. What about the reactivation or risk of reactivation? A lot of studies that discussed the immunosuppression risk of reactivation of hepatitis B virus. Alkylating agent like cyclophosphamide were associated with a high risk of hepatitis B virus reactivation. So it is not preferred. What about cyclosporin or CNI? As you see, calcineurin inhibitors were associated with a low risk of hepatitis B virus reactivation. In another study, calcineurin inhibitors were associated with low to moderate risk of reactivation. So my opinion for the preferred initial treatment between CNI and cyclophosphamide based on the medium risk for progression of membranous nephropathy and the lower risk of hepatitis B virus reactivation with CNI, I would prefer to start treatment this patient by CNI, not cyclophosphamide. 1.3, GFR is 67.
Okay.
Dr. Ahmed.
Okay, so let's move to our patient. The patient actually started a Ponticelli regime. Unfortunately, he did not respond. Then he used a IV cyclophosphamide. This was not under our supervision. Unfortunately, he did not respond. I don't know why he used the IV cyclophosphamide after finishing a Ponticelli regime, but this is what happened. So we shifted to cyclosporin, but unfortunately, again, in a subdose, which was not even up to 4 milligram per kg of his body weight. And he had initial resistance. When he increased the dose to 150 milligram twice daily for 12 months, he had a good response and started on gradual tapering. And this is the patient follow-up of the anti-PLAR and the urinary ACR. With the Ponticelli and urolupus, he was still positive. The anti-PLAR antibody was highly positive. And cyclosporin 4 milligram per kg, it started to decrease, and the proteinuria as well decreased. Later on, in 2023, was still negative with an anti-PLAR and controlled proteinuria. In 2024, he had starting recurrence. Proteinuria was around 1 gram, but still anti-PLAR negative. And this is important to monitor the patient using the anti-PLAR as well as the proteinuria. Again, just a month ago, or even less than a month, the patient had a full recurrence with a 4,850 milligram of proteinuria, and the anti-PLAR again recurred to be positive, though not high enough. So the question now, this patient who initially responded to high dose of cyclosporin and not to cyclophosphamide, and he relapsed with tapering of the cyclosporin after more than a year. Would you restart cyclosporin or give him rituximab? Professor Hassanin.
So for the sake of time and really in like exactly 1 minute, for this patient, I would have given rituximab from the very beginning. So the evidence comes from the Mentor trial. Rituximab was non-inferior and even superior in maintaining long-term proteinuria remission. As we know, rituximab is a monoclonal anti-CD20. It's a chimeric molecule, basically originating part of it from mice and part of it from humans. The new derivative is obinutuzumab, and this is more humanized than ofatumumab. That's the full human monoclonal antibody. So, long story short, rituximab addresses the underlying pathophysiology of PLA2R membranous, when you deplete the B cells, you are decreasing antibody production. It's effective in preventing relapses. It's not nephrotoxic compared to CNIs, and it's preferred in patients with non-adherence. However, you have infusion reactions unless you use obinutuzumab. There's a risk of reactivation of TB and hepatitis B. However, this patient had negative PCR and was on entecavir as well. It's expensive, and there's a risk of hypogammaglobulinemia and infection.
Professor Mamdouh will defend of restarting cyclosporin. We're from Egypt. We don't have that much of rituximab, Professor Hassanin.
Okay, my opinion is to restart cyclosporin again. I will apply the same rules which I put in initiating treatment. What the Kitigo said in relapse, if the patient started CNI, like in our patient, or cyclosporin, we can treat relapse by either CNI or rituximab. So the next rule is what is the risk of reactivation for both of them between CNI and rituximab. Again, rituximab is associated with a high risk of reactivation of hepatitis B virus, and CNI was associated with a low risk of reactivation of hepatitis B. Again, in the same research, rituximab is associated with high risk of reactivation. So my opinion for the preferred treatment for this relapse, based on the initial response, the patient responded before completely to CNI, and the low risk of hepatitis B virus reactivation with CNI, I would prefer to treat this relapse by restarting CNI or cyclosporin, not to give rituximab for the fear of high risk of reactivation of hepatitis B. And thank you. أنا ما وقفتش.
وقف السايكلوسبورين وقف بعد سنة ونص من الريميشن.
بروفيسور أحمد
وصل، ما هو كان اقل من 500 والانتي بلار بتاعه 7 for a longer time. ما هو are you 2 years? Yes,
2 years. It should be at least 2 years.
what about the hep B status? What is
he had already 1.5 years after remission.
what about the hep B status at this time? Because you said that he was treated for 2 years only.
Yeah, no. He was 2 years negative PCR. Negative PCR since 2 years, and he was still on entecavir.
But you know that EASL guidelines suggest that treatment of hepatitis B means hepatitis B surface antigen loss, which is theoretically is very bad. Then why we didn't think out of the box and we do liver biopsy to see the hepatitis B core antigen from the start, and if there we can suppose that it is associated with the membranous
This is an academic point. I mean, but for a patient who is repeatedly hepatitis B PCR negative with no transaminitis, with no liver affection whatsoever, and is doing good on his membranous side, we're not going to offer him a liver biopsy, actually. And the hepatologist did not, we asked the hepatologist for their opinion, even regarding the rituximab, and they agreed that.
Yep.
So
I just take the final comment
I just want to make a point that I once had a patient who had PGNMID, proliferative glomerulonephritis with monoclonal immune deposits, latent hepatitis B, active hepatitis C. And what we did was we gave entecavir, we gave active HCV treatment and rituximab. And that's after clearance by the infectious disease doctor.
Okay.
Thank you.
The last thing, that we should take care of the reactivation of hepatitis B. Hepatitis B virus is more tricky compared to hepatitis C. Very, very tricky hepatitis B. We should be very careful while introducing immunosuppression.
Thank you. Thank you all. We have to move, unfortunately, because we lack time and we've been ordered to finish earlier. So I call for Professor Riyad Saeed to come for the stage. We don't need to introduce Professor Riyad Saeed. He's, as I've only just said, Sheikh al-Nephrologist al-Arab. He's our professor, and he's came all the way from Jordan. Jazallah khair. Been joining us in all our previous meetings since I joined nephrology, which was back 1994. And unfortunately, we missed the Professor Ghuraymat. He should have been with us, but he had an urging, appointment that he cannot postpone. So he sent his slides. I'm going to share the slides in a hurry with Professor Riyad. And this is a case of IgA. As you can see, this person is, the slides were showing, she is, how much is she? She's 28 years old, female, who presented to the clinic with for a routine check because of her family history. His father is on maintenance hemodialysis, had a normal blood pressure, normal heart rate, and a good, excellent BMI, no edema, no rash, no joint pain, normal renal function, but she had microscopic hematuria and 1+ proteinuria. Her quantification was less than a ½ gram per day. Should we biopsy that patient or not? So for Professor Ghunaymat, he said probably not at this stage. Why? Because there are many complications of the renal biopsy that you have to be aware of, and because of the indication of a biopsy in a patient who is presumed to be an IgA nephropathy, if you have a significant proteinuria, if you have a persistent macroscopic hematuria, or an impaired kidney function, which is not the case, or a persistent hypertension, which is not the case, and so this patient is not a candidate for biopsy. And these are the red flags that you should go for biopsy with. And this is the presentation of Professor Muhammad Ghunaymat. Professor Riyad has a different opinion.
well, أولا شكرا جزيلا للجمعية المصرية. شكرا دكتور أحمد. طبعا when we look about this patient, where we fit her, if she's really risk of progressive kidney disease or not. If you look about her, she's 28-year-old, estimated GFR around 95, because really I don't have her weight, but that's approximately. Urine albumin creatinine ratio, it's A3. So if we are putting her into the heat map, she's going to be really a high-risk patient. She's okay. So this patient likelihood to progress to is very high. Now, when we look about a patient with IgA nephropathy, it's really recognizing it's a heterogeneous disease. The key point really is in this situation. We have to look about hematuria, proteinuria, estimated GFR, blood pressure, use of ACE inhibitors, age and race, and the biopsy with the MIST score, and whether there is immune suppressive therapy or not. And these are currently really what are the indication to the kidney biopsy, at least in adults: asymptomatic urinary tract urinary symptoms, microscopic hematuria, mild proteinuria after we exclude orthostasis, and the patient with CKD. We agree that this patient is CKD. She is CKD class 1A3. And in children, usually persistent screening, hematuria, especially in the Asian countries, they biopsy every patient with hematuria, and if there is a gross hematuria. So yes, this patient, in my view, with the risk of high progression, she needs a kidney biopsy.
Okay, so kidney biopsy was actually done, and we all know the diagnostic histological marking of an IgA. We've just mentioned that in the morning, and we have to go for the MEST or MEST-C classification. And the biopsy showed a MEST-C score of M1, E1, S1, T1, and C0. And this is a tricky biopsy. And would you treat this patient, would you treat this patient or not? This would be the question.
Well, again, the definition of IgA is a biopsy. Without a biopsy, you cannot really diagnose IgA nephropathy. So we agreed about that. And in this patient, really, she is M1, E1, S1, and T1. So really, this is a high-risk patient. Definitely, she will need to be treated. If we look about for most of patients with IgA nephropathy is a lifelong relapsing remitting progressive disease with high lifetime risk of kidney failure. And if you look about the natural history here, it's two parts of the disease. The initial part is an autoimmune, which is really deposition of the immune complexes in the kidney. And then later on, as you'll see here, you're going to see the CKD part. So we have two parts of IgA nephropathy. It's an autoimmune, which is Ig deposits, and we have the CKD. We have to take care of these. Luckily enough, I think this patient presented here in the middle way where we have a therapeutic area that we can treat this patient. Yes, this patient should be treated. And how we predict, all of you are familiar with the international Ig prediction tool. At the biopsy time, you can really log in and you'll see where we stand. We looked information about this patient. The risk of 50% decline in the initial eGFR of presentation to end-stage kidney disease 5 years from now is around 6%. But this is really a lot of limitation for this formula. It's a retrospective historical. Not all patients in this category, they were on RAS inhibitor. None of them used to be an SGLT2 inhibitor, and only predicts up to 80 months, around 6 years. And our patient, this patient is 28-year-old, and she can live up to 70 at least. So the likelihood, if you tell her that you're going to be 50%, you're going to have 10% now, I think she should be really treated. Now, what's the outcome here? This is a nice radar study from the UK, as you'll see. 50% of their patients, they develop around 2,900. 50% of them, they develop end-stage kidney disease in their lifetime. And not only that, the mean kidney survival was 11.4 years, and the mean age at kidney failure or death was here. So it's really continuing trouble for such patients. So the recommendation is, that's again kidney guidelines, recommend all patients who are at risk of progressive kidney function loss with IgA nephropathy be treated with an optimized, maximally tolerated dose of ACE or ARBs. Then I added here in red down, SGLT2 inhibitors should be really added. Control blood pressure to target less than 120/70 with RAS inhibitor as the first choice. Lifestyle modification should be stop smoking, weight reduction, diet, sodium restriction, regular exercise, and we should take care of really all risk factors taking cardiac. Exactly like any patient with CKD that we treated. The situation should be ACE, ARBs, SGLT inhibitors, and nowadays, basically, you may have to use mineralocorticoid receptor blockers.
So the patient was chosen to start conservative treatment, and she already started conservative treatment using the SGLT2 inhibitor and the RAS blocker. She was put on that, and these are the slides for Professor Ghulaimat as well, showing the algorithm and the KDIGO 2024 using the RAS and SGLT2 is the baseline, and then you can add the sparsentan, which again is non-immunosuppressive treatment. ET1 receptor antagonist is a non-immunosuppressive treatment, so conservative versus immunosuppression. His opinion is you should not start immunosuppression in such a patient. There is not so much added benefit within a 10 years of follow-up, whether you receive steroid or you don't receive steroid, based on the STOP IgAN trial. Although the testing might say something else, the patient was put on SGLT2 inhibitor, and she was definitely not added the endothelin. Also, Professor Riyad will show the proof for using sparsentan.
Well, again here, if you look about this, really, the endothelin receptor, how they really function, they are really leading to vasoconstriction, cell proliferation, inflammation, apoptosis, and fibrosis. So really, this is the damaging part of that endothelin. Now, the endothelin receptor blockers in IgA, sparsentan as a PROTECT study, and the affinity study also, they showed good result really in the interim part, 48%. Okay, when they treated with irbesartan alone versus the sparsentan, which is the dual function, they found that really with sparsentan around 90, almost 49.8% reduction in proteinuria versus 15%, with very little side effect, mainly fluid retention and all that. So it has been recommended highly to be used. Again, this is really the study around 200 milligram initially, and then up to 400 milligram versus irbesartan 150, and they continued for almost 110 weeks. As you'll see, the quite beneficial effect really of the drug. They concluded once daily treatment with serbestan produced magnificent meaningful reduction of proteinuria compared with irbesartan alone with IgA nephropathy. Safety was really more or less the same. So the recommendation really, it has been suggested that patients who are at risk of progressive kidney function loss with IgA nephropathy be treated with serbestan, which is recommended 2B category.
Professor Ghunaymat also pointed to the atrivantan, which is a selective endothelin A1 receptor antagonist that is now in phase 3 randomized blind placebo-controlled trial, and it showed as well preservation in the proteinuria and in the GFR within almost 2 years, with, as you can see, greater benefit as compared to placebo, with minus almost 40% improvement. Our patient, definitely, we don't have the AT1 receptor antagonist, so she was put on ramipril according to her blood pressure. She did not tolerate a higher dose on dapagliflozin 10 milligram. After 3 months, the patient came for follow-up. Her creatinine is 1.2, and the proteinuria increased from a sub 500 milligram per day to 820 milligram per day. So would you start at this point an active immunosuppressive treatment for her, or you would still wait? And what would be the agent, Professor Riyad?
Well, I think patient, again, KDIGO guidelines, a patient with IgA nephropathy is at risk of progressive loss of kidney function if they have proteinuria more than 0.5 gram per day or equivalent, while on or off treatment for IgA. And the recommendation is treatment or additional treatment should be started in all cases. And that's really what this patient fits for. Now look about the significance of proteinuria. The amount of protein that we used to say less than 1 gram is quite good, your patient is good, that's no longer really valid. Because if you see here, even proteinuria less than 0.5 gram per day, the risk of developing end-stage kidney is 22%. If you go further up to 2 grams, you're going to be 85% of your patient, they will have end-stage kidney disease. And the target should be less than 0.3 gram per day. And that's here looking about the importance of proteinuria. As you'll see here, when you have proteinuria between less than 0.85 in purple, you have 65% the likelihood of survival, kidney survival. If you go into the yellow, usually less than 25% survival. And that's really quite significant situation. So we have to control proteinuria to the maximum. Is this patient needs active treatment? Yes, she should receive active therapy. What active therapy really we have? You remember about the multi-hit model of IgA nephropathy, where you have the galactose deficient IgA production by the B cells, and then you have antibody for it, which is HIT2. Then you have the combination between the autoantibody and the antigen, call it. So you have immune complexes, and then in the immune complexes will be HIT4 deposited in the kidney and in the mesangium. Once that happened, you're going to see glomerular injury, you're going to see inflammation, you're going to see tubulointerstitial scarring. So you have two kinds of diseases, inflammation and glomerular disorder, plus really the chronic kidney disease that you're going to have. And where we stand really, that's again, everything has been changed. In fact, in the last year or so concerning IgA management, this patient should have identified as two kinds of diseases, not one disease. The immune complex, which is really resulting from the precipitation of the immune complexes, the inflammation, and the other one, CKD, that all of us, we are familiar with. I think we spoke about the first part as conservative, and then we have to see what other therapies that really we have. This is really the pillars of IgA nephropathy treatment nowadays. Goal number one, just mitigating the consequence of nephron loss by RAS blocker, SGL2 endothelin. We discussed that. And then you have the goal 2 and goal 3, basically, which is immune disease. You have to have systemic steroid or complement way, and then stopping the production of the IgA, galactose deficient IgA. And luckily enough, which is ongoing so far, is the stage 4 ongoing therapy. This here will show you exactly, I put it for you. Number one, stop really the glomerular hyperfiltration and tubulointerstitial disease. Step 2 in blue, systemic growth therapy to avoid glomerular inflammation. And then in 3, you may have to stop really B cell priming it, inhibiting its function, and usually try to prevent formation of the immune complexes as a whole. I'm done here.
So the multi-target approach, as you can see, is using both the attacking the glomerular inflammation, and this might be accomplished by systemic steroids or by complement inhibitor, beside taking in consideration the preservation of the kidney, residual kidney function. Okay.
So now the story of steroid, all of you have heard about it. One time it's good, the other time it's bad. So really the latest, you heard about the stop IgA nephropathy, and you heard about the testing. Now really the recommendation is to go with what we call testing studies, when they compare methylprednisolone study versus placebo in almost 500 patients, and you look about methylprednisolone group, around 28% reduction in the amount of protein. That really was a very good thing, while the other they did not really respond. So the primary outcome occurred significantly in patients who are treated with steroid therapy. Yes, there are some complications. We have to bear in mind infection and the other complication of steroid therapy.
So again, the testing was positive, demonstrating that the treatment with methylprednisolone for 6 to 9 months significantly slow the disease progression, as you can see.
Which is the inflammation, yes. So the recommendation really now, this, in a setting where Nefecon, which is, we'll talk about it now, is not available, we suggest that patients who are at risk of progressive kidney function loss with IgA nephropathy be treated with a limited course of reduced dose of systemic steroid regimen combined with antimicrobial prophylaxis after thorough toxicity risk assessment. And then we know that, steroid, if you can't use systemic, let's use it locally, which is the target release formula. And Nefecon, as you'll see in IgA nephropathy, where really it will attack the Peyer's patches, where you have the production of the B cells there, the antibodies, you try really to suppress its production. Hopefully, then the galactose deficient IgA antibodies will be decreased. So by this, you are going to avoid having the disease process. Are we really doing good? Yes, I think this NAFGARD trial, which is 2 parts, part A, which has been compared urea production almost by 0.68 versus 0.09 for placebo at 9 months. And then the estimated GFR, it has preserved almost 0.17 ml per decrease versus 4 ml decrease, so at 12 months. So that really was a good study. Recommendation, if you don't have this, we don't have it. I don't know, do we have it here?
No, we don't have Nefecon yet.
It's very expensive. It's very expensive. I think the last question was, are we going to use C5 inhibitors or not, which is really the complement part.
Yeah, so this is the last question in the last minute. Would you use a complement inhibition in this patient?
I think yes. look about the iptacopan, which is really the factor B inhibitor, where you can stop really cleaving factor 3 into 3A and 3B, and then you can prevent formation of C3 convertase and the down cascade of the complement system. You can block all that, as you'll see with this red arrow. Anything below that is going to be stopped. So really there is the inflammation is going to be blocked. So yes, there is a good studies about this here, and the applause study, which is IgA nephropathy, at least specified period of time after 9 months, it worked very well and showed evaluate the benefit and safety of iptacopan, which can be given as an oral medication. Usually it's there, but I don't know again whether we have this here in our area or not, but it's working well. Now the last one really about the C5 inhibitor. C5 inhibitor, as you'll see again, C5, this is the revinumab, which is a monoclonal antibodies, inhibit or bind C5, so it prevents its cleavage between to 5A and 5B, and usually it will prevent the further damage, which is the membrane attack complex that you can have that. So it's there, and this is
Dear
really
doctor,
a nice
your
study,
time is up.
which is the last one, showed a good benefit in around 48 patients. They have good reduction of amount of proteinuria. So really, it has been changing a lot. We used to say 0.8 to 1 gram, that's perfect achievement, but that's really no longer. You should go really for less than 0.3, which is a drastic level. I don't know whether we can achieve it or not with the current medication that currently we have, and we don't have hands on the new medication, which is very expensive. Thank you.
Thanks, Professor Riyad. Thanks, and thanks for Professor Raimat in his absence. Yes. Yeah, unfortunately, the time was, yes. Okay. We move to the next presentation.
We will move to the next talk.
Yes.
Professor Samir Kamal and Professor Amir Oqaili.
Yes, Professor Amir Oqaili, Professor Samir Kamal, please join the stage. And this is an ANCA-associated vasculitis debate. We'll just start the case scenario. And this patient presented on 3 phases. First phase was in 2021, where she accidentally discovered renal impairment with a positive ANA. No biopsy was done at that time. Please do not treat patients without a biopsy. Although her renal function was high, she only received dexamethasone and oral steroids. And though her serum creatinine went down, so presumably she was suggested as an tubular interstitial nephritis. But again, less than a year later, she received the vaccine for COVID, and she developed the infection as well for COVID as well. This was followed by increasing in her creatinine to 1.6, after which she had a biopsy at that time, and she was started on cyclophosphamide. 8 days later, when she was started on the cyclophosphamide, we saw the patient. She was positive for P-ANCA, negative for C-ANCA, and atypical ANCA as well. Her creatinine was rising to 1.44, and proteinuria was almost negligible with a positive RBCs. The biopsy showed 40 gloms, 8 of them were globally sclerotic, and 2 of them were segmentally sclerotic, 5 with sclerotic nodules, and there was mild interstitial lymphocytic infiltration and moderate intimal sclerosis, and it is a focal necrotizing sclerotic glomerulonephritis with less than 10% crescents, going with an ANCA-mediated vasculitis, and the patient was known to be a P-ANCA patient. So now these are the set of the question. Provided the given medical history and the lab result and the biopsy finding, would you start this patient on immunosuppression, or not? And if you would start it, what agent would you use for that patient? And would you recommend heavy induction, provided that the patient creatinine is 1.2 to 1.4? And would you consider plasmapheresis in this patient or not? Let's have a flew through the ANCA with Professor Samir.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. Congratulations for the board of ESNT for this successful event. Before going to answer this question, can I ask you a question about this case? Will you treat this case as a newly diagnosed vasculitic attack or a relapsing case of vasculitis? And does it matter? Some may say it doesn't great matter because induction and reinduction may be the same. Another opinion says that no, it is a matter for the choice of induction and the duration of maintenance that may affect the outcome. What is ANCA-associated vasculitis in brief? And I'll be in a hurry not to encroach on the talk of Professor Amir. ANCA-associated vasculitis is a rare multi-system autoimmune disease characterized by necrotizing immune small vessel vasculitis. The primary affecting organs is the kidney, lungs, ear, nose, and throat, and musculoskeletal system. The phenotypes, our clinical phenotypes is GPA, MPA, or eosinophilic GPA. The estimated overall annual incidence is about 30 to 20 case per million, and the prevalence is about 300 to 400 case per million. The pathogenicity of ANCA antibody mediate excessive activation of neutrophils, which result in small vessel vasculitis. The activated neutrophils lead to the production of inflammatory process with libration of cytokines, reactive oxygen species, and the formation of neutrophil extracellular traps that lead to the vasculitic lesion. The pathogenic role of ANCA subtype is more relevant than phenotypic diagnosis in clinical presentation, diagnosis course, disease course, pattern of biomarker regulation, the treatment response, and comorbidities. So for the research purpose and increasingly in clinical practice, the stratification of the patient with the ANCA-associated vasculitis is usually based on the ANCA subtype rather than the clinical phenotypes. ANCA testing is very important. It is a cornerstone in the diagnosis. It may improve the outcome, not to delay the diagnosis, to wait for the biopsy diagnosis. It is the first step when suggest a case of vasculitis to do ANCA testing, and all guidelines recommend the starting diagnosis if positive ANCA in the serum beside the clinical suggestion of vasculitis. The testing of ANCA is better to be by ELISA rather than indirect immunofluorescence. ANCA testing is not a golden test because some fallacies may occur with the negative or the positive, and we need to test for anti-GPM because of the overlap syndrome. There is a typical variance of ANCA, may be positive with immunofluorescence and negative with ELISA in case of some drugs, infections, connective tissue disease, cystic fibrosis, inflammatory bowel disease. Also, the classification or the categorization according to the biopsy is important in prediction of the outcome. If there is more than 50% globally sclerotic, this is the sclerotic class and this is the worst outcome. And is it more than 50% of the glomeruli are normal? This is the focal class, which is the best prognosis, and our patient is lying in this category. So, to induce immunosuppression or not for this patient, answer is yes, because this patient is a typical case of B-ANCA vasculitis, so induction is a must. We can induce what? With methotrexate, according to the NORAM trial. Yes, it is comparable to cyclophosphamide, but not in, it's ideal in renal involvement. It is better in non-severe diseases, non-renal vasculitis. MMF may be an alternative for induction of remission for MPO-associated vasculitis. According to the MyPsych trial, comparable with cyclophosphamide 6 months, maybe an alternative induction agent for MBO, ANCA-associated vasculitis, but not MB3 associated vasculitis. Rituximab produced a revolution in the management of ANCA-associated vasculitis, and this is the most famous randomized controlled trials using rituximab in the induction and maintenance. I choose this for the induction, the rituximab and the RAVE trial in 2010, actually comparing rituximab to the cyclophosphamide. In the rituximab, the non-inferior to cyclophosphamide in the induction of remission. Also in the RAVE trial, also rituximab therapy was not inferior to daily cyclophosphamide oral, but in the relapsing disease, it was better than cyclophosphamide. We can combine rituximab and cyclophosphamide. The rationale is to block the precursor of autoantibody producing cell by rituximab and by cyclophosphamide to target the autoantibody producing plasmablast and the short-lived plasma cell to allow a rapid tapering of high dose of steroid. This is the retrospective trial for the combination of rituximab and cyclophosphamide. This is the conclusion. The remission is better in the rituximab combined with cyclophosphamide in severe diseases. And the patient presented with dialysis was the outcome is less than the patient not on dialysis at presentation, and the patient reproduced B cells was less than the patient not producing cells. This is a protocol for the combination of rituximab and cyclophosphamide.
ساوند يا جماعه.
So the answer of the first question is yes, we have to use immunosuppression. I prefer to start with rituximab therapy as an induction for the case with rapid steroid tapering. The dose of rituximab is that of the treatment of lymphoma. For doses 375 milligram per square meter, and we can give 1 gram every 2 weeks to sustain remission of the disease. No need for considering plasma exchange because we have no severe renal disease and we have no alveolar hemorrhage. Okay.
So for sixth time, we'll move to the next part of questions, and we might skip some of the Professor Samir answer and invite Professor Amir to continue. How long would you use the induction, or how long would you as well choose, or what agent would you choose as the maintenance for this patient? This might be on the BVAS trial, and Professor Samir was intending to show us the study and the mainstream study and the Rituximab in comparing the azathioprine versus the rituximab. His opinion was to maintain the patient on rituximab for a longer time as a maintenance, not as an induction, and the patient was maintained for a long time on MMF, and she had a very good response. Then she was shifted for azathioprine. Unfortunately, she had transaminitis and leukopenia, so she went back to MMF, and she was doing very good on the MMF till she started to taper after almost a 2-year full dose of MMF. When she started tapering, unfortunately, just a couple of weeks ago, she relapsed again, and she had a higher level of B-ANCA after being negative for a while, and she had as well recurrence of her proteinuria with rising of her creatinine from a baseline of 1.2 to 1.4. So she was re-put on MMF again. These are your set of slides. Professor Amir will continue.
Assalamu alaikum warahmatullah. First of all, I would like to thank the organizing committee for giving me the chance to be with you today. Actually, you haven't got a lot of controversy in our presentation today because we got a lot of guidelines, and the last published guideline was the KDUKI Guideline 2024. What did they say? What did they say? For management of ANCA-associated vasculitis, we usually start by diagnosis of ANCA-associated vasculitis and start to put our patient in one of two categories. The first one is no organ-threatening involvement. If we got this group of patients, we usually start by rituximab plus glucocorticoid with quick tapering of the dose, or if we want to avoid glucocorticoids, we can use C5 receptor antagonist avacopan. The other arm may say that we can use cyclophosphamide plus glucocorticoid tapering or avacopan. But for another group of patients with vital organ, life-threatening, and serum creat plus 3.4 milligram per deciliter, we can use rituximab plus cyclophosphamide or cyclophosphamide plus glucocorticoids or avacopan. This is according to the KDIGO guideline. When the disease control or in drug remission, we usually maintenance either continue rituximab or switch to azacitidine and taper glucocorticoids. This is the first one. So if we are going to choose to select whether rituximab versus cyclophosphamide, rituximab may be referred in children and adolescents, premenopausal women and men who are concerned about fertility, frail older adult, patient who view glucocorticoid sparing are especially important, and patient with relapsing disease and patient with proteinase 3 ANCA. These are group of patients may got the maximum benefit from rituximab. What about cyclophosphamide? Cyclophosphamide may be preferred in some situation if rituximab is expensive or difficult to access. In the presence of severe glomerulonephritis, especially if serum creat more than 4, IgG level should be measured because it usually reduced with rituximab, leading to increased incidence of infection. البوينتر مش شغال يا دكتور احمد. For the choosing, are we going to start with oral cyclophosphamide or intravenous cyclophosphamide? Actually, oral and intravenous cyclophosphamide result in similar outcome. Intravenous cyclophosphamide, there is a reduction of the total phosphamide dose is achieved compared to those needed with oral cyclophosphamide. Patient treated with intravenous administration may have increased relapse due to small dose. Frequent monitoring for treatment toxicity, in particular leukopenia, is quite important in this group of patients. And as we said, patient with intravenous cyclophosphamide who already have a moderate cumulative dose of cyclophosphamide, lower white blood cell count, patient with ready access to infusion center, patient who may have trouble adhering to an oral regime. On the other arm, oral cyclophosphamide, patient for whom cost is an important factor, patient for whom a self-administered oral regime will not be difficult. What about the other issue regarding the guideline? From 2021, American College of Rheumatology and Vasculitis Foundation, they published this guideline in 2021, and they start by active severe GBA or MBA. We usually recommend induction therapy with rituximab over cyclophosphamide. So they prefer rituximab if compared to cyclophosphamide, and reduce dose of glucocorticoids over standard dose of glucocorticoids. If we got remission induction with rituximab, recommendation for maintenance, rituximab may be methotrexate or azacitidine, MMF or leflunomide. If we don't get remission, recommend switching to different remission induction agent like rituximab or cyclophosphamide over combining both rituximab and cyclophosphamide. Also in active non-severe GBA, which is a condition in our case, recommendation usually start by glucocorticoids plus methotrexate over glucocorticoids plus rituximab, cyclophosphamide, AZA, or MMF. Regarding remission induction, we may continue on methotrexate, azacitidine, or MMF. If no remission induction, consider switching to a different regime, maybe rituximab or cyclophosphamide. And this is the conclusion from the American College of Rheumatology criteria. In patients with GBA and MBA with active glomerulonephritis, we conditionally recommend against the routine addition of plasma exchange to remission induction of therapy. This is the first point. In patients with active severe GBA with alveolar hemorrhage, we conditionally recommend against adding plasma exchange to remission induction. And the issue in this point that alveolar hemorrhage usually got rapid response with immunosuppressive. Plasma exchange may be considered for certain patients with active glomerulonephritis or those who are critically ill and whose disease is not responding to recommended remission induction therapy. Plasma exchange remains advisable in patients with GBA or MBA who have antiglomerular basement membrane disease, which may be associated with ANCA vasculitis. What about the third guideline from the rheumatology point of view, which is the ULURAR recommendation for management of ANCA-associated vasculitis?
Your time is up.
Can you give me more 2 minutes? Because you take from my time about 5 minutes. 2 minutes. 2 minutes. ULURAR recommendation for management of ANCA-associated vasculitis for induction of remission in patients with new onset relapsing GBA or MBA with organ-threatening, life-threatening disease, treatment with combination of glucocorticoids and either rituximab or cyclophosphamide. Rituximab is preferred in relapsing patient. As a part of induction of remission in GBA, treatment with oral glucocorticoids with quick tapering. Plasma exchange may be considered as a part of therapy to induce remission in GBA or MBA for patients with serum creatinine more than 3.4 milligram. Routine use of plasma exchange to treat alveolar hemorrhage is not recommended. What about cyclophosphamide plus rituximab in resistant cases? Data regarding the efficacy of combined cyclophosphamide and rituximab for remission of induction remains limited and it is not recommended in the United States of America. Actually, the time is very short and I think I go through most of the guidelines, and if there is any questions, I'll be happy to answer the question. Thank you very much.